Hey, welcome back to the Health Bridge. Dr. Pedram Shojai here with a special episode. We're talking about something serious today. It is opioids and the problems we're having with prescription drugs. My guest today is absolutely phenomenal. We are talking to Dr. Deborah Houry, who is the director of the CDC's National Center for Injury Prevention and Control, and also a practicing ER doc. And I love that because she's actually still seeing patients, which makes a big difference. Here's the problem. Prescription sales of opioids like Vicodin, Percocet, and all these things that we keep hearing about in the news have quadrupled since 1999, and now the CDC is moving to do something about it. More than 40 people die every single day because of this. It is serious, and so we have really gone too far, and now the CDC has kind of stepped in with some guidelines that we're going to talk about because it's become a problem. Dr. Houry, welcome to the show.
Good morning. How are y'all?
Doing great. Thanks for being here. I know you're in Atlanta at
Yes.
CDC. Yeah, so what is the CDC's role in this epidemic?
So the CDC's role is to protect the public 24/7 from different health threats, and that includes things like opioid overdoses. And specifically to this topic, I'd say there's a few areas we really see as the bread and butter for CDC. And one of those would be tracking data and trends. You see us do that with many other topics. So we look at the number of deaths, the number of prescriptions, and look for specific populations, states, or areas to really target for interventions. We also work directly with states and state health departments. And so we received an increase in FY16, and we'll be rolling out a national program with all the different states to really combat this epidemic. And the third thing is tools for healthcare providers. So things like the opioid prescribing guidelines that we released last month really want providers to have tools at their fingertips to help address different health issues, and in this case, opioids.
So how bad is it? How serious is it? I mean, you guys are seeing the data come in, and so obviously it's a cause for concern. What's going on with it?
So I think, you mentioned that I'm a physician, and so I see both sides of it. I have seen the numbers increase, and so I see it at the macro level, but then I also see the faces of this opioid epidemic. I've seen people come in, and I've had to tell loved ones that they've lost a family member from an overdose. I've seen patients coming in with addiction and not realizing they're addicted and asking for different pain medications and having those difficult conversations, as well as patients that do need pain medicine and sometimes their medications aren't working with them. I believe doctors are trying to do the best that they can, and I speak from personal experience. When I went to medical school, I wasn't trained a lot on appropriate prescribing and the risks and benefits of opioids, and didn't know a lot about addiction and different pain options. And so over the past 10 to 15 years, we've seen an increase in prescribing. It's actually quadrupled in the amount of prescribing since 1999. And at the same time, we've seen the deaths skyrocket to match that.
Yeah, and so these have been prescribed for patients who are in pain. And look, if you're in pain, they work great, right? I mean, this is what they're for. You have a herniation in the disc, you have, severe migraines. I mean, there's people who have debilitating pain, and these drugs are actually quite effective for that. But there's a point where it kind of crosses over, and then we're in trouble.
Well, and what I would say too is that the data for long-term effectiveness of these medications isn't that strong. If you look at acute pain, the evidence does show that these medications can be very helpful. For long-term pain, there haven't been any randomized controlled studies really looking at opioids versus placebo, or no pain medication for over a year, looking at effectiveness. So we really can't say that they are effective. And over the past few years, we've had more studies showing the risks of opioids. So I think it's really looking at the risks and benefits. What is the medical condition the patient has? Are there either non-pharmacological options like physical therapy or biofeedback that might help? Or are there other non-opioid medications? Some antidepressants like amitriptyline can be very helpful for neuropathic pain. Non-steroidals can be helpful for inflammatory conditions. So really taking a step back and looking at the full picture.
So now, I believe there were 12 recommendations
Yes.
that the CDC's made. Can you kind of get into that and what the key recommendations are?
Sure. So I'd say The main recommendation is to start or to really utilize non-opioid medications, that opioids should never be the first line for chronic pain. When you read the guideline, it doesn't say opioids should never be used. It just says that non-opioids should be the first line, and that means non-opioid medications as well as non-opioid pharmacological, non-pharmacological therapies. Again, like physical therapy, biofeedback, sleep, all that really holistic picture. When you do use opioids, they should be used in conjunction with non-opioids. So opioids themselves should really not be given alone. It should be in conjunction with these other medications. So that's our main recommendation. The other really main bucket recommendation I would say is when you do utilize opioids, start low and go slow. So start with the lowest dose possible that's effective for the patient. And if you do increase it, do it slowly and monitor the patient.
So how's this different from how we used to do this? Were the guidelines before this, were they just a little less stringent on that?
So this is the first time CDC has issued guidelines, actually that the CDC has issued guidelines on this topic. There's been other medical societies that have issued guidelines as well as some state medical boards, but they have really differed on what type of patients they're targeting it towards or which providers. Some are for pain specialists, some are for specific types of patients. We really wanted to focus on primary care providers, as that's where more than half of all the prescriptions for opioids are coming from. And it's one of the groups where we're also seeing increases in opioid prescribing. Some other specialty groups are decreasing in their amounts of prescribing.
That's interesting. So in the old days, you'd go to a physiatrist, you'd go to an orthopedic surgeon, you'd go to a neurologist, some sort of specialist, and then they would kind of escalate up the algorithm. Now we're seeing over half of these prescribed kind of on the family practice GP level. Is that accurate?
Yes,
Yeah.
and many of these patients might have started off, after a surgery with an orthopedic surgeon, then get referred back to their family physician for longer term care. And I also think we've seen management of these conditions like fibromyalgia and back pain and migraine headaches in primary care clinics with the use of opioids. And that's one of the areas to where there's been even less evidence that opioids are effective for long term.
So is it the patient that's kind of going through and asking the doctor for it? In some cases, is the doctor being lazy? I mean, what do we attribute this? I mean, it's just someone's asking and someone's prescribing.
I think it's a combination of many different factors. And I'd say one is, a lot of physicians didn't know about a lot of the risks of opioids and didn't think about the long-term effects and how they can be really addictive. Patients also, I can speak from my own practice, when I would give somebody a prescription for ibuprofen, would say, give me a real medication. So not seeing something you might be able to get over the counter as a real medication, wanting something stronger, saying, you don't believe my pain. When you do believe their pain, you're just trying to give them something safer. So I think it's really about educating both providers and patients about the risks and benefits. It is difficult to have some conversations with patients when they come in and say, this is the prescription I want. To say, this is what is best for you, given that you've got neuropathic pain or you've got spinal stenosis. Here are some different options that would be helpful for you. It takes a minute to write a prescription. It can take 10 minutes or longer to have those conversations. And over the years, I saw my own practice changing to where somebody would ask for a prescription and didn't like the one I wrote. I initially would change my prescription. Then over the years, I started realizing I wasn't helping patients the way I really should be and could be. And so started talking more about patients, about the risks and benefits and other alternatives.
Yeah, and we live in a society that just loves its instant gratification, and it's people want what they want, and they've been on the internet, and so
Yes.
it's a big challenge. So let's just define these real quickly, just for our listeners. OxyContin, Percocet, Vicodin. What else is in this class of drugs?
Methadone is also in this class of drugs, fentanyl as well, and all of them really have different types of delivery methods. So fentanyl you can actually have as a patch, and some of these other medications can be pill or injectable. But I'd say the ones that you mentioned are the most commonly prescribed.
Yeah. And so what are they usually prescribed for? Like what conditions?
So I think that's one of the things we need to look better at is where's the evidence best for these for these different types of conditions. For acute pain, after something like a fracture, a lot of medications like, Vicodin or Percocet, could be very helpful in the short term. Longer term, these medications do not have, they're not shown to be as effective when you look at long-term randomized controlled trials. Part of that is because you can get tolerant to these medications. And so over time, the medication you thought was helping your pain, you now require 10 times the dose to get that same effect. So essentially, you start not having the same effect from the medication. And if you stop taking it, you can start withdrawing. And that's very unpleasant and uncomfortable for patients. And some will go on to be addicted to it as well. I would say you look at the risks and benefits for each patient. For somebody requiring palliative care, the risks of opioids, are not the same, and the benefits are probably greater for them to use an opioid. So again, looking at each specific patient and each specific condition.
Yeah, it's tough because, first of all, when you're in pain, it's something you don't want to suffer, right? And so some people don't know the threshold of what point that medication is actually going to, be helpful, versus putting them in Betty Ford or, it happens very quickly. And one of the things that I've seen over here, it's a big problem in Southern California, it's a big problem everywhere, is, it's also become a party drug, right? And there's a lot of kids, stealing it from their parents and taking off and finding ways to get it, which I'm sure isn't helping these statistics.
No, it's not helping the statistics at all. And actually, we found that 3 out of 4 heroin users had been abusing prescription drugs before. And so that's the issue, is people will go from one opioid to another. And so that's why we really want to make sure people are not starting these drugs unnecessarily, because they are addictive. Yep. And one of the other guidelines is really about when you start a patient on opioids, you discuss the risks and benefits with them, and then you reassess them, really much as you would with any other long-term medication, particularly one that has risks. Anywhere from every few weeks to every 3 months, depending on the dose and the type of opioid given.
So we had this big problem. Back in my practices, when we first brought on a physiatrist, which is kind of a pain management specialist, all of a sudden a different type of phone call started coming into our office. And it was people just saying, hey, my name's John Smith, I'm calling for my refill. And my staff would be scratching their heads trying to figure out who this patient was. And it turned out he wasn't a patient of ours, right? And it was always someone trying to dupe a doctor's office into a refill to go get their fix. And this is obviously a big problem all over the place. Is that part of the solution, is to really control the refills and really control the flow of how often this stuff can get out? I mean, your first bottle gets out there, but then afterwards you got to talk to me?
Well, so I think we don't really support giving just refills unnecessarily. You would reassess the patient. We understand that in rural areas, or just sometimes schedules don't work to where that patient can't come in time to get that refill. But we have a checklist on our guidelines, and it says if you can't see the patient in person, make sure their follow-up appointment is rescheduled within a short period of time when you do give that one refill, but you don't make it a continued habit. I would also say there's 2 really useful tools, and we mentioned them in our guidelines. One is the prescription drug monitoring program. So check that before you write an opioid for the first time, and then check it on a fairly regular time interval, maybe every 3 months, every 6 months, depending on how it is in your state, because some states have more user-friendly PDMPs than others. But this will tell you, is my patient getting opioids from another provider? The urine drug screening test is also helpful. You can see if a patient is diverting opioids, if they're taking other medications. There has been, questions about, is this a violation of patient-provider, trust and confidentiality? But I view it as something as, with Coumadin. Before I start a patient on Coumadin, I want to know what their PT-INR is. So before I start a patient on a long-term addictive drug, I want to do a urine drug test and just monitor it the same way. I think we need to think of it in medical terms versus stigma. We're doing this for a patient's health.
Well, and the flip side of that addiction is, it devastates your family, it devastates your brain, it devastates your physiology. I mean, it's really, really ugly. right? And it's not something we wish upon anyone, let alone the people that we've sworn oaths to take care of. So it is our responsibility to take care of that. And so what's the doctor's role in making sure the patient isn't harmed? Because the challenges with healthcare and managed care and all the issues that we have today is that no one's got time to sit there and talk to patients. No one has time for anything, and it's just become such a stressful kind of debacle that doctors are struggling to keep up on charting, let alone pay attention to when this person's refill was. So how do we slow our roll a little bit to make sure that this doesn't happen over and over again?
So I think we go back to the Hippocratic Oath and first do no harm. So as simple as that. I mean, if you're prescribing a medication that has an addiction potential and truly a fatal consequence, you need to be monitoring your patient. And so when they come back in, ask how they're doing. And this is really involving the patient. What is their quality of life? And it doesn't mean just using a standardized tool. We do have one called the PEG that we list on our checklist, but it's also things like, can I, go to the grocery store? Can I play ball with my kid? Things like that. What's important to the patient? We also made a point, though, of not screening patients and saying somebody's at particular risk for addiction, because with opioid medications, anyone can be at risk for addiction. What we want providers to do is recognize when a patient is starting to exhibit addiction, or if a patient comes in with addiction, to then refer them or to start medication-assisted treatment for patients.
Mm-hmm. And there's a lot of ways to deal with this now. I mean, we know a lot more about this today than we did a decade ago, and obviously it's become a problem. No one thought this would be a street drug, and all the problems that we're having, across the board in this. So, how much? I mean, people have had blind faith in their doctors, and so how much do we need to question kind of the MO, not the MO, but kind of just the rationale and the decision making of our doctors as we're going through? Because I'd say 95% of our listeners are normal people, right, who go to doctors, right? So this isn't a doctor to doctor thing. So how do you know if maybe your doctor might be being lazy?
So I wouldn't say that the doctor's being lazy. They might just not be as informed about some of the more current risks of opioids. So through these guidelines, we're working with different medical organizations to see if there's ways to get them really integrated into electronic health records, to where there's prompts for that, to get different organizations to include it in their journal publications, physician newsletters, to make sure there's a lot of awareness about it. And then this summer, we also hope to do a communication campaign for patients and the general public around the risks of opioids, so that they also know, ask your doctor. I view this as a two-way street, that patients should say to a provider when they're given a prescription, how will this impact me? Mm-hmm. And providers need to be able to answer, here are what your risks are and here are what the benefits are. And we probably haven't been doing a good job of that as providers until we became more aware of these risks of opioids. So now's the time to really start doing that. And patients should feel empowered to ask their providers.
Yeah, and this thing just kind of came up on a groundswell. It's like everyone's siloed in their own little universe doing what they do. And now it's just created such a kind of a tsunami of news that is obviously all kind of of concern, that now obviously we're talking to the CDC about it. Like this has become a thing. So are there any kind of age demographics or anything we're seeing where people skew towards more addictive personality, more addictive behavior in this?
So I wouldn't say that there's a particular age group for the addictive behaviors, but when we do look at overdoses, we're seeing them from opioids, the prescription opioids, we're seeing them in Caucasian, non-Hispanic men, 45 and up is where we're seeing the highest rates of overdoses from prescription opioids. But when we look at heroin and the recent increases in that, we're seeing really dramatic increases in almost all age groups and demographics, but really strikingly in the younger. So like 18 to 25 is where we're seeing a lot of really dramatic increases.
Right, and that's the party drug recreational piece, or is that also kind of medically derived from the start, or we don't know?
So we don't necessarily know, and it can be both. And I think a lot of it, too, is that heroin has become much more accessible in this country, and it's much more potent, and it's become relatively inexpensive. And so if somebody tried a prescription opioid, whether for medical use or for non-medical use, and then wants to get something with a similar feeling, they can go on to take heroin or fentanyl.
Yeah. Long cry from when I was growing up.
Yes.
Things are different. So the FDA also came up with a new warning label requirement, kind of around the same time, I said it was about a week after that, for opioid painkillers and the risks of that. Do you think that that's going to have any sort of impact? Obviously it's helping in the right direction.
I think everything helps at this point, and the secretary has been really instrumental in making sure we're coordinated across all the different federal agencies on our position on opioid and how we can make a difference. And so I think FDA's doing this is really an important step to really share the risks and benefits of opioids with patients. This is almost like the Surgeon General's warning years ago when it was put on cigarettes, about the risks of cigarettes. Now people are aware of what are the risks of opioids.
Yeah. And they should be. And so then the challenge is the other side of the spectrum, right? So the doctors, is there any pushback from, say, the AMA or any of the state boards saying, hey, listen, this is just more of you encroaching in how we do our thing?
So we had a public comment period when we developed our guidelines, and we received 4,372 comments. It was one of the largest number of comments received at CDC for a guideline. And we received 160 medical organization or community organization letters. And the majority were supportive. There were some that were not supportive, concerned about autonomy, legal implications, things like that. But the majority of medical organizations were supportive. And I believe the American College of Preventative Medicine, American College of Physicians, American College of Emergency Physicians, American Society of Addiction Medicine were among the ones that came out within a day of our guidelines being released with press releases supporting these guidelines.
Great. So this is obviously something people want and need out there. And it's a big challenge. I mean, if you're on the front lines, it's so hard to know if someone's playing you or actually in pain. And so how do you assess that? And you got 30 other people in your waiting room and you're just trying to help people. So it's a challenge. It's a challenge across the board. What about Big Pharma? Are they for it? I mean, it's a label and it's also a guideline. Does that hit them in the pocketbook, or is it something that they're also cooperating on?
So to be honest, we received over 4,000 comments. We did receive some from pharmaceutical companies, from many different facets of the guideline. It's hard to say really what their view on all of this is. I think it depends on which medication they're making. I think this is a great opportunity to really look at new research into non-opioid medications, as we've really heard a lot from patients about the lack of other options. So this is a great time and need for pharmaceutical companies to look at other non-opioid medications and development in that area. And I think just really keeping in mind, too, that these are guidelines. They're not regulatory. And I use many different guidelines in my practice. And it really depends on the patient in front of me and if it makes sense.
Yeah. Well, I guess the end of the road on this is to really shift consciousness and to kind of shift the perception of this so that there's more awareness on the side of the end user and the physician. So do you see that happening already? Is that going to be a long road to hoe?
I think it's a long road because of where we've gotten ourselves into. I mean, if we've quadrupled the amount of prescribing, from where we were in 1999, and if you compare us to other countries, 80% of opioids are consumed in the U.S. compared to other countries in the world. But that being said, I'm very optimistic that we can really turn this epidemic around. And I think the partnership of all these different medical organizations, the comments I read from physicians on the front line saying we need these guidelines, we need to be able to communicate with our patients, and the stories from families who lost loved ones or had people dealing with addiction asking for advice on how to really address this. We did hear from concerns from patients saying opioids are what work for my pain. And we want to really be responsive to patients and say we're not trying to cut you off medications, but we do think it's really important for a provider to talk with you about the risks and benefits, and you be part of that decision.
Yeah, and that's the challenge. It's like, look, no one's pulling the drugs off the shelves here. We're just opening up a conversation about the risks and the rewards of using such things. And look, the opioids have been used since time immemorial in different forms for pain, right? I mean, they work. But the problem is they're addictive, and so it creates a whole other piece there. What about the states? Are they in on this? Are they supportive? I'm assuming they're picking up a lot of the healthcare bills.
Yeah, so through one of our state programs, it's called PDO Prevention for States. It's where we're funding different health departments to really institute different interventions for around opioid prescribing, as well as healthcare interventions. States have, they're on the front line. They're seeing these increases. So particularly if you look at groups like Appalachia or the Northeast, where they're really being hit hard, states have been really receptive to the guideline, as well as just different ways that we can partner and look at policies that they're implementing in states, so where we can evaluate what if something's effective. Like Florida really looked at their pill mill laws and changed them and saw a decrease in overdoses. So looking at what policy states are implementing that are effective, and then sharing those with other states.
Kind of reminds me in a way of the, we had the kind of crack cocaine epidemic in like the 80s, and then from what I understand, you know this way better than I would, is then they kind of swam upstream and started just kind of preventing the DARE programs and all sorts of kind of like childhood awareness programs. And then within a generation or two, we saw a real dent in that kind of crisis. Is that also, I mean, the problem with this is it's not just like a cool recreational party thing. At any given point, you bang your knee, you go into your doctor, you can very well fall into this challenge as well, right? So it goes across all ages.
Absolutely, and I think what makes this different too is that a lot of times when you get medication from a provider, you assume it's safe and that you need it, and so questioning again, do I need this medication? What are the risks and benefits? That it may not be safe. It can be addictive. And, depending on what painful condition you have, it may not be the best treatment for you.
Yep. And there's so much cool stuff out there now. I mean, acupuncture's been there forever. It helps a lot of people. There's, biofeedback, like you mentioned. There's neurofeedback. There's all sorts of like crazy, like transcutaneous, like head scalp stimulation and all sorts of stuff that kind of lands on my desk that has interesting promise that is non-addictive. It may not be as effective, but long term, hey, listen, you're not addicted to a drug, and you can manage your pain. That's a conversation that we need to have.
And actually, many of those treatments can be more effective than opioids.
Yeah, exactly. And so that's also a piece of it, right, is just taking a cold, hard look, like you mentioned, at the long-term efficacy of this stuff. I mean, short-term, hey, look, it helps. It's like it takes the bite off pretty quickly, but if you're still on an opioid 2-3 years into a condition, that's kind of a slippery slope. And I think that's, a big problem with what we're talking about here. What about the public? What can we all do in the public to kind of bring this to light? Are there stories that can be shared? How can we get this out there?
So we are planning on doing a public awareness campaign this summer. So I think, people sharing stories is really important. Last year we had a social media campaign. It was called #RxProblem. And people shared their stories on Twitter about loved ones that had died or their own personal stories of addiction. And that was really powerful because it showed, somebody you might know or somebody in your community sharing their stories, and it went viral, lots of retweets and lots of people participating. So I think the more we can do things like that to get the message out, I also think the public should really feel empowered to speak with their providers about what is the best treatment option for me and what are the risks and benefits of an opioid when they go in, as much as you would with any medication. So I think really thinking from that mind frame is important. And if you suspect it in a family member or a neighbor, ask them, because we really want to make sure if people are addicted to these medications that they get help.
And then who do you call? Let's just say you have someone in your inner circle, you suspect it, you start to realize that maybe it's gone a little too far. Is there a resource? Is there a hotline? Do you call their doctor?
So the SAMHSA, the Substance Abuse Mental Health Services Administration, their website has many different resources, including to where you can look at your zip code and identify a provider who can do medication-assisted treatment near you.
Yeah, great. And then in terms of these CDC guidelines, I'm assuming most of this went straight to physicians or physician offices. Is there a resource on your .gov or something that people can find?
Yes, cdc.gov/injury, and we have all of our All of the topics for our injury center are there, as well as for on our drug overdoses, and there's information on there for the public too.
Great, great. Dr. Houry, thank you so much. This is really important work. If you're on the front lines, you're seeing it way more than you'd like to see. And if you're listening to this right now and you're like, well, I don't know what they're talking about, this doesn't relate to me. First of all, you wouldn't be here this long in the conversation, but more importantly, you've got to understand that this is happening around every corner. You walk into the mall, there are people in there that have this problem right now, and you wouldn't be able to know it. And so it's time to bring the awareness up.
Absolutely. I hope today that this saves, at least one life and makes the awareness out there, that much more so, and really appreciate the opportunity to have this discussion today.
Hey, thank you for doing the work that you do.
Thank you.
All right, you heard it from the source itself. This is obviously a problem. We're going to put links to where you can get more information if there's someone in your life that you suspect has a problem like this, or if you have a problem with addiction, with painkillers, with opioids, with any of these things that we've been talking about, there is help, there are resources, there are other ways. Now is the time to get out ahead of it. Just waiting a little longer is just going to make it that much more difficult. We're going to get links in there for you. Thanks for being here. Dr. Pedram Shojai, The Health Bridge. I'll see you next week.